Respected chairpersons, seniors, and my friends, I'm going to be talking about the ocular anatomy to introduce all of you to the structures which make the eye and which we will be referring to as the day progresses. Amongst the 5 senses that we have, eyesight is the most crucial of all senses because 75% of the information that we have about the world comes from the sense of sight. And that itself tells us how important it is to look after the eyes. And in fact, it is the sense that one fears to lose the most. And so the talk today is not only about how we need to take care of our employees and other people, but also of our own selves, our families, our neighbors, and how a little more awareness will help us improve the ocular health of everybody around us. So if we look at the basic structure of the eye, this is how the eyeball appears. The eyeball is a very delicate structure which is housed inside the orbit, the bony walls, which make a sort of a surrounding cushion for the eyes, within which is fat and within which is the eyeball. The average length of the eyeball is about 23 to 24 millimeters. People with myopia or nearsightedness will have a longer eyeball. People with hyperopia will have a shorter eyeball, with even a 1 millimeter difference in the eyeball length causing a refractive error of about 3 diopters. So if we look at the orbit, orbit takes the brunt of the injury whenever any object hits it. So the orbit is made by the frontal bone at the top, the sphenoid and the ethmoid medially and inferiorly, and the temporal bone forming the lateral border. Also, outside the eyeball, we have the eyelids, which have a very important role in protecting the eye, and not only protect it from dust and foreign particles, but are also the first defense line whenever any object hits us or if there is any injury coming from the environment. Also, the position of the eyelids will act as an indicator of the other diseases that the patient may having. For instance, paralysis will cause drooping of the eyelid. And on the other hand, a wider opening eye may be seen in patients with thyroid problems. So just examining the eyelids, if you're a little more aware, will act as a clue to what other problems the patient may have. The eyeball is surrounded by the extraocular muscles. We have 6 extraocular muscles, the superior and the inferior rectus for superior and inferior movements, the medial and the lateral rectus, and the 2 obliques, the superior and the inferior oblique. Now, these muscles could, of course, get damaged or trapped into the orbital walls, and then you could have a patient presenting with acute squint or a misalignment of the eyes. At the same time, we might have children, either in the family or neighborhood or even amongst our workers, who would have squint, and often we think these patients can wait for a long time. That is not true. Even a child with a squint needs to be evaluated. They may have associated vision problems. A malalignment of the eyes may be the first sign of an eye disease. And maybe early rehabilitation, early intervention could not only improve the eyesight, but will also improve the depth perception and the 3-dimensional appreciation of things. The next important thing that we encounter in everyday life is dryness, especially coming from using a lot of computers. So remember that the eyelids should normally have a blink rate of about 15 times per minute, and for computer users it may go down, causing dryness. So for all our computer user employees and ourselves, it's important to tell them to blink frequently. And now we come to the inside of the eye. So the outermost structure is the conjunctiva. The conjunctiva lines not only the eyelids but also the eyeballs. It is a thin, vascular, transparent membrane surrounding the eye. The part of the conjunctiva which lines the eyelids is called the palpebral conjunctiva, and the part of the conjunctiva which lines the eyeball is called the bulbar conjunctiva. So just checking the appearance of the conjunctiva will act as a guide to what problems we have. A very common thing we have is the red eye or the eye flu appearance. Now, these could, of course, be infective, like bacterial or viral, but it could also be allergic because of the dust or the fumes that the employees or the workers are exposed to. So paying a little more attention to the surrounding structures. Is there associated lid edema? Is there an associated discharge? Is there associated stickiness or matting of the eyelids? Will help us to possibly diagnose and treat them better. The next structure is the sclera, which is the white of the eye. And this covers 5/6 of the eyeball. It's like the eggshell of an egg. So it is that white structure. It is an opaque, thick layer, which again protects the eye from significant injury. It is the coat which kind of protects all the internal, more sensitive structures. The thickness varies from about 1 to 0.3 millimeters, but it is vulnerable to trauma or vulnerable to injury at the site of the muscle insertions, at the limbus, and at the insertion of the optic nerve. Inflammations of the sclera may also appear as redness of the eye, so they have to be distinguished from the redness of the conjunctivitis, and so maybe a more detailed examination may be needed. This can also come in association with arthritis or other immunological problems. The most important structure of the eye in terms of the contribution to the power of the eye is the cornea. The cornea is an avascular transparent structure which is in the center of the eye, which is sometimes in fact invisible because it is transparent. But this contributes 2/3 of the power of the eye. So the normal power of the eye is about 60 diopters, and the cornea itself contributes about 40 to 45 diopters. That is 2/3 of the power. It is made of 5 layers, the epithelium, which is about 50 to 60 microns thick. And this can regenerate, this can recover if it's damaged or abraded by injury. The next layer is the Bowman's layer, and then we have the stroma, which is contributing the majority of the thickness. It is this parallel arrangement of the fibers of the stroma which maintains the transparency of the cornea and is hence responsible for good vision. And inside the stroma is the descemet membranes, and the innermost layer is the endothelium, which has the pump which maintains the hydration of the cornea. So people with endothelial damage, as in Fuchs dystrophy or sometimes post-surgery, may have loss of the endothelial cells, and so the cornea may get swollen and hence turn opaque eventually. So the structures of the cornea are very, very important, and they're very essential that they stay healthy so that the vision is maintained. So this shows you how the light is transmitted, and majority of the power, like I said, comes from the cornea, after which light travels through the pupil via the lens and goes on to the retina. So when we have to treat patients, it's usually the corneal change in power or change in shape that is giving them a refractive error. And most commonly, what we use to treat these refractive errors could be glasses or contact lenses. But the most recent changes that we have been, in fact, doing in technology in treating the cornea are the laser vision corrections. So what I wanted to tell you was that the laser vision corrections are all that we'll talk about subsequently, are all targeted at the cornea to correct the power. And that is the structure we are always referring to. Often people get confused between cornea and the other structures. The other common corneal problems that you could encounter would be the arcus senilis, the white ring that develops on the cornea with age. A corneal abrasion is a very common injury which can occur with a finger poking or injury with a pencil or a pen or any sharp object, which will be associated with acute pain, watering, and inability to open the eyes, and which can be easily treated with a little bandage and with antibiotic and lubricant drops. Most significant injuries are bacterial or viral infections of the cornea causing ulcers. And of course, we should be aware of a rapid change in power occurring because of change in the shape of the cornea, and that is keratoconus. So anybody around you who's having a rapid change in power of the eye, especially in the age group of 10 to 15 years, could have keratoconus and hence needs to be referred to an eye specialist so that it can be diagnosed and treated. When we talk about eye donation, it is the cornea that we are trying to treat in terms of taking it from the donor patient and transplanting it onto the recipient's eye. And it is essentially just the cornea that we are using. So after the cornea, let's look at the other structures. We have the iris, which has a central aperture called the pupil, which regulates the transmission of light. So the pupil will constrict in bright light to reduce the amount of light entering the eye so that there isn't any further damage. And in dim light conditions, the pupil will dilate. So it essentially acts as the camera aperture. And behind the pupil lies the lens. Between the lens and the cornea, we have the anterior chamber, which is filled with the clear fluid called the aqueous humor. So this aqueous humor is a clear fluid lying between the cornea and the iris, and it provides nutrition to the cornea and the lens, removing waste products. This is secreted by the ciliary epithelium, and this is how the aqueous flows from the posterior chamber into the anterior chamber and then flows out. And this is a very important component of the eye pressure that we often talk about. And any alteration in this flow, maybe a decreased outflow, will cause an increase in eye pressure and lead to a condition called glaucoma. Glaucoma may be asymptomatic in majority of the people, so a measurement of the intraocular pressure and an examination of how the anterior chamber is. Is it shallow? Is it wide open? Are there any cells in it? How clear is the fluid? Will act as a guide for us to diagnose glaucoma, the various types of glaucoma, which could be open angle or closed angle, and then to help prevent further damage, because the damage with glaucoma is irreversible. So after the part of the anterior chamber and posterior chamber, the next thing is the choroid. The choroid is the vascular structure between the sclera and the retina and provides the blood supply and the nutrition to the retina. And of course, we could have choroidal tumors, choroidal melanomas, which could be damaging, and then, of course, age-related changes could be happening there. The next important structure after the cornea is the lens. Now, the lens contributes the remaining 1/3 of the power of the eye. So the approximate power of the lens is about 15 to 20 diopters. It is transparent in young age, essentially made of water and soluble proteins. But as we age, the lens opacifies, and we get the most commonly associated eye problem, which is cataract, and that can be treated easily with cataract surgery. There are lots of technological advances that we'll be talking about later. But the lens is the structure which is controlled. The movement of the lens is controlled by the ciliary body and the zonules. And this also, the loss of accommodation is what we see in individuals around the age of 40 years, when we might feel a reduction in our near vision and may feel the need for near vision glasses. Between the lens and the retina, we have a gel-like fluid called the vitreous humor, which is again made of water, collagen, and hyaluronic acid. And this again will liquefy with age, and that's where we might see people complaining of black floaters or objects floating in the eye. And they may be very disturbing, but we need to reassure our patients that they're usually innocuous. Very rarely, they can be, of course, associated with retinal tears and cause retinal detachment. So these are the age-related degenerative changes which will be happening in the vitreous. And then the next layer is the retina. The retina is essentially the film over which the light, which is getting transmitted from the cornea and the lens, is then getting processed at the retina and then traveling upwards via the optic nerve fibers. The retina is made of 10 layers, and all the ganglions and layers eventually combine together to travel via the optic nerve. Now, we're all very familiar with the fact that there are two main kinds of receptors in the retina called the rods and the cones. The rods help us to see even in dim light conditions. They're very sensitive to light. So whenever there is less light, even then we are able to at least have the perception of dark and light. And that's because of rods. However, the cones are the ones responsible for color vision. But the cones need to have good light to really work in. So when we have very dim light, we may not be able to discriminate color. But in bright light, we're able to appreciate color better because of the function of the cones. The cones are most concentrated at the macula. And at the center of the macula is what we have the fovea, where the concentration of the cones is the maximum. The most common disorders of the retina are age-related macular degeneration. So we may have people complaining of central loss of vision. In diabetes and blood hypertension, we may have damage to the blood vessels of the retina, which will cause leakage of blood into the vitreous chamber, into the vitreous humor. And of course, retinal detachments that could cause a sudden loss of vision, with a patient complaining of something like a curtain falling in front of their eyes. These will be dealt with in detail subsequently. Also, examination of the retina could reveal cotton wool spots, which could happen not only in diabetes, but also in conditions like central retinal vein occlusion or even in HIV retinopathy. Commotio retinae is what we see in patients who have sudden blunt trauma. And of course, papilledema could happen with optic neuritis or even with brain tumors. And finally, like I said, all the fibers get together and travel via the optic nerve to the brain, to the visual cortex, which is the occipital cortex. And the axons, which originate in the ganglion cell layer of the retina, will finally synapse in the lateral geniculate body. So as the nerve kind of travels across the brain, we can have lesions along this pathway also that will cause various visual problems. And sometimes we find that the patient first comes to the eye specialist. And that is where, looking at the kind of visual defect they have, we may actually be able to pick up a tumor or a compressive or vascular lesion anywhere along the path of the optic nerve. And hence, just the examination of the eye could be helpful in diagnosing a much more serious disorder as well. Also coming back to glaucoma, so even though we are only able to see the 1.5 millimeter optic nerve head when we're examining the eye, we can also diagnose more serious problems, like I said. The other thing is glaucoma, where the appearance of the optic nerve head is affected. So the normal appearance shows a cupping of about 0.3 to 0.4 compared to the optic disc. But in patients with glaucoma, we'll find a very pale or an enlarged optic nerve cup, and that will help us to diagnose and assess the visual damage the patient has and treat it. So to conclude, just examining the eye structures helps us to see so many more serious problems, and just a little care and attention when we are treating a patient or examining a patient will help us, of course, not only to treat their local eye infections like a viral or a bacterial ulcer or a fungal ulcer or a keratitis or a conjunctivitis. This, of course, is part of the first examination. But like I said, the position of the eyelids could tell us their thyroid status. Patients with ankylosing spondylitis or sarcoidosis or more immunological disorders may also have eye lesions that could help us to diagnose something that maybe even the physician is missing. Control and treatment of diabetes and hypertension, and even gestational diabetes and hypertension, is helped by an eye exam. More serious problems like brain tumors, multiple sclerosis, will be reflected in the examination of the optic nerve head. Looking at the eyelids and the health of the conjunctiva cornea would tell you how healthy their eyes are, especially in patients with a lot of usage of computers. And of course, the more regular aging changes of the eye, like cataract, glaucoma, age-related degenerations, all of them can be treated, and we can improve the eye health. So just looking at the eye structures, the anatomy, will help us to kind of make the eye health better. And like they say, eyes are not only the windows to the soul, they're also the windows to the body. And while we look at every structure in detail, these are a few simple precautions that we recommend all healthcare professionals when they're looking at patients to follow, to at least protect themselves and the people that they are treating. But that kind of wraps up the ocular anatomy in simple, basic terms.